I am Valentin Fuster from New York. We are in Orlando, the scientific sessions of the American Heart Association, and I'm here surrounded by a team of 5 stars. And I'm going to introduce one by one, starting in my right, Dr. Gillis, who is President-elect of the Heart Rhythm Society, Professor of Medicine at the Leibniz Cardiovascular Institute, University of Calgary. John Chapman, John, we have seen you here before, is the director of the Dyslipidemia and Atherosclerosis Research Unit at the National Institute of Health and Medical Research at the Hôpital de la Pitié-Salpêtrière, University Pierre and Marie Curie in Paris, France. Dr. Bill Boden, Professor of Medicine and Preventive Medicine at University of Buffalo School of Medicine and Biomedical Sciences Division of Cardiology in Buffalo. Now we have here Dr. Keith Fox. I gave him a beta blocker because he came too energetic today and we have to cool him down. So you will see him a little bit asleep at the beginning. He's the president of the British Cardiovascular Society, Duke of Edinburgh Professor of Cardiology, University of Edinburgh, and head of Medical and Radiological Science and Consultant Cardiology at the Royal Infirmary in Edinburgh in Scotland. We have Dr. Jessica Mega, who is actually the first author of the paper that we are going to be discussing today in a few minutes, from the Brigham and Women's Hospital, investigator at the TIMI study group at Harvard Medical School in Boston, and Dr. Clyde Yancy, also known to many of you as the Magister Professor of Medicine, Chief of Cardiology, Northwestern University at Feinberg School of Medicine in Chicago. Well, thanks to all of you to be here today. I think it's going to be an interesting session, I predict, because I see there are 2 challenges today in our enterprise in the cardiovascular field. The first challenge is the specialty has become so technologically oriented that the question is, are we really capturing what the patient is trying to tell us? That's the first issue. And the second issue is we are really presenting here the academics, the details, the p-values of trials, how these affect us as we deal with the patient. We can give 7 drugs, but are they taking them? That is, these are the 2 gaps that we have, and we are going to really approach today the second one by presenting 2 trials on antithrombotic agents, and finally, are patients taking the drugs? So this is going to be the discussion today. So we are going to start by presenting a study that gave a lot of talk and made Dr. Jessica Mega more famous by being the first author of the paper, just published yesterday in the New England Journal of Medicine. And this is a paper that was presented by Dr. Michael Gibson, and is the so-called Atlas ACS2 TIMI 51 investigators trial, and has to do with the role of a 10A inhibitor, rivaroxaban, in patients with acute coronary syndromes. As you know, the time has gone through the oral antithrombins, and now it came into the 10A inhibitors, and then we will be talking to about another class later. And the 10A inhibitors many were suspicious that might not work because of bleeding, because what the 10A inhibitors do, they really end up blocking thrombin, which is an activator of platelets and is an activator of fibrin formation. And in fact, there are some studies already in acute coronary syndromes, for example, apixaban, which was discontinued, at least for those syndromes, when aspirin and clopidogrel were given to the same patients because of bleeding. And even the Atlas 1 phase 2 study of 3,000 patients using the same drug by the same group in acute coronary syndromes in dosages between 5 and 20 milligrams, and they found promising results in terms of preventing events, but also problem of bleeding. So we have a background which is a little bit worrisome. However, something very smart was done is to drop the dose of rivaroxaban to a very low dose between 2.5 and 5 milligrams twice daily, and that's how the study took off. And I'm going to relate for you very briefly what the study is all about, and then we'll have the discussion. Basically, this is a double-blind placebo-controlled trial of 15,000 patients with a recent acute coronary syndrome, which were entered into the study within a period of a week of the syndrome. Interestingly, this was a high-risk group. Those patients under the age of 55, either they had previous myocardial infarction or they had diabetes. The patients received twice daily the dosages of rivaroxaban of either 2.5 milligrams or 5 milligrams or placebo. That is, we have three groups. For a mean of 13 months and up to 31 months was the follow-up. The primary efficacy endpoint was a composite of death from cardiovascular causes, myocardial infarction, or a stroke. These patients, of course, receive aspirin and one of the P2Y12 inhibitors, clopidogrel or ticlopidine. So therefore, we have a cocktail here of three antithrombotic drugs. It was also smart to exclude a number of patients, those who have GI bleeding, cerebrovascular or cerebral hemorrhage in the past, stroke, TIAs. So there were a number of exclusions which are interesting when we talk about the real world that we deal today. Now, let's go into the results. Rivaroxaban significantly reduced the primary efficacy endpoint as compared with placebo, with respective rates of 8.9 and 10.7%, which is a 16% reduction. Now, interestingly, the twice daily dose of 2.5 milligrams reduced significantly the rate of death by 34%, something that didn't happen with the 5 milligram dose. This really needs intellectual discussion. And as compared with placebo, rivaroxaban increased the rates of mesh bleeding, 2.1% versus 0.6%. This is 4 times of the control. An intracranial hemorrhage from 0.2% to 0.6% without a significant increase in fatal bleeding. So we can summarize, this is a smart trial in the way it was designed, a very low dose of rivaroxaban, excluding a number of patients that could lead into trouble, and we ended up with significant bleeding, but still the primary endpoint was very forceful. And so therefore, I like to first of all, I will exclude Dr. Fox, who is ready to speak, because he was part of the study. I will exclude for a moment Dr. Jessica Mega, and maybe I can start with Clyde to ask you an overall view of this. Is this a big breakthrough?
It's a big step, maybe not a breakthrough, because remember, we already knew from data amassed years ago that anticoagulation after heart attack was a good thing. We just couldn't do it practically speaking because warfarin was our only choice. Now we have a regimen that adds improvement in outcomes, but there's some very precise issues that have to be respected as we interpret this, and particularly as we try to put it into the clinical context. Can we make this happen in the real world? That's a big question.
Bill, what is your reaction?
I think it's a very important trial. I really do. I'm hesitant to, be too theatrical and say this is a game changer. But I am really impressed with the fact that this is a drug in that lower dose that had such a significant effect. I'm not quite sure I understand the discordance between the 2.5 and the 5 milligram dose with respect to cardiovascular mortality, and it does raise some issues as to mechanistically what could be driving that. But I think this is going to be another agent that will be in the armamentarium of physicians taking care of patients with ACS.
John, how things look like from France?
It seems to me that therapeutically there's a tremendous need in this area, and we all acknowledge that. But the question that occurs is the one that you asked, Valentin. How will we manage to interpret this trial and apply it in a real life situation? And I'm actually unable to answer that in practical terms. One of the questions I have relates to the pharmacology and the pathophysiology here, with such a mixture of agents that act on so many different factors, both in terms of thrombin generation and the overall mechanisms that contribute to thrombus formation. So I'm afraid that there are a number of questions, both in terms of patient care as well as the pharmacological mechanistics that are involved here, and one of those Bill mentioned, which relates to dose.
And can I ask you, you deal with electrophysiology, and you are now ablating everything around, and you are getting rid of drugs. How do you react to all of this? We are giving more and more.
Well, certainly polypharmacy is a major issue for patients with heart disease, because as studies evolve and we make new observations about new classes of drugs that seem to have benefit, patients are on more and more drugs. Here, as has been pointed out, it was a very carefully crafted study in a very select group of patients. An impressive observation, particularly with the reduction in mortality. Struggling to understand the mechanism by which this has happened, and also thinking about how broadly this can be applied to the general population of patients with coronary disease. And then there's also the cost factor of all of the drug therapies, and trying to understand the risk-benefit and cost-benefit ratio.
Jessica, the overall feeling, as you can see, is very positive. So a significant step forward. Now, let me ask you, you have given a lot of thought. How is possible you decrease mortality with a low dose significantly? You don't touch it with a higher dose. What are your thoughts?
Well, I think it's the question on a lot of people's minds. To think about it, in my mind, the pathobiology in the setting of an acute coronary syndrome, there's thrombus formation, there's activated fibrin and platelets, and as was mentioned, it makes sense that in the hospital we treat patients with anticoagulants, we treat them with antiplatelets, we only send them home on antiplatelets. And so the question you ask is, how can an anticoagulant reduce death? And I think that it's two different pieces, the way I see it. The first one is that there was a reduction in stent thrombosis with these doses. And it makes me think that there was also a reduction in sudden cardiac death. And so with the lower doses, I think that can be appreciated. And the higher doses, when you look at the 2.5 and compare it to the 5, there was more bleeding with the 5 milligram dose. And so the 5 milligram dose overall reduced the primary endpoint. It's just that it didn't reduce death. And I think it's a consequence partially of the fatal bleeding, although that numerically cannot explain it. So then our question is, well, what happens when someone bleeds? Do they go off some of their other therapies and therefore didn't have a mortality reduction?
Keith, maybe I'd like to ask you a different question, something that maybe is not commented on, but I was very surprised positively. The curves tend to diverge over time, and this is a study contrary to most of the antithrombotic studies, in which you see the great effect at the beginning, and then the curves go parallel.
I think there's something very interesting, and you know, we've seen in some of the long-term studies the fact that the event rates continue over the course of time. There is good evidence about the early platelet activation, and your work and many others have shown that, but thrombin generation also continues. And I think the very interesting result from this study is it said that in the presence of dual antiplatelet therapy, inhibition with a small dose of anticoagulant has an additive benefit. And I think that is a step. And I think that's an important step. And I would challenge you, John. I think that actually 90% of people who are getting dual antiplatelet therapy in the US today are still getting clopidogrel and aspirin. And, here's something that can be given as part of the secondary prevention treatment. Now, if you were to say they're on ticagrelor, that's a challenge, because aspirin ticagrelor is another alternative. And do we know whether this would work on top of that? No, we don't.
Keith, there's some similarities between rivaroxaban and fondaparinux. I mean, that's a indirect 10A inhibitor, but as you well know, tested on across a broad range of dosages. And as you may recall in the OASIS studies, it was the lowest dose, 2.5 milligrams a day.
We chose the lowest dose in those studies.
And again, the curve, the benefit was not observed until 30 days and 6 months. So the curves continue to diverge. So there are some similarities.
But it's also biologically plausible. If you look at the APPRAISE study that used the AF dose of apixaban, then there was no benefit in terms of the efficacy, but increased hazard. So I think Jessica's exactly right. I think there is hazard of major bleeding, maybe from bleeding itself, but also cessation of the antithrombotics that's provided hazard in the higher dose group and has been unmasked in the low dose group.
Clyde, I have a question for you. When you concentrate on the bleeding here, I'm sure that some data monitoring committee would have stopped the trial. I'd like to present this to you. The bleeding rates is 2.1% measured bleeding rates versus 0.6%. I only present this to you because I know trials have been stopped with the rates of bleeding much less, and actually we are going to discuss one of these trials in a moment.
Right.
And I'd like to see how you react. Is because the event rate, let's say thrombotic, was so significantly decreased that you work on a balance, but we are really in a very narrow window here when we deal with our patients. Who do you exclude, who you don't, because it's really not so simple. I'd like to have your reaction, then I will ask the reaction of both of you who have been so involved in the trial.
You have to applaud the discipline of this DSMB. Giving a drug, an anticoagulant in this setting, and anticipating that the risk would indeed be bleeding, and seeing evidence of slightly more episodes of bleeding really would give you pause as a member of the DSMB. But remember, they have the totality of the information in front of them. And depending on how those data are processed, and especially depending upon the stopping rules, you might say, let's watch and follow a little bit longer. And fortuitously, they made a decision that allowed us to see the complete development of these data. But to get back to the points that we were making, this really underpins my original statement. In the confines of a well-constructed clinical trial with rigorous oversight and capture of events, and many, many people really focus on what's going on, we saw these outcomes. What happens in general practice where we don't have the rigor and the oversight and the structure of a clinical trial? A narrow therapeutic window, benefit at 2.5 but not at 5, and a risk of bleeding that may be amplified in a less selected population. I think it really is a step forward, but I think we really have to give some thought to how we convey this message to the general community so these results can be replicated.
This is a very good comment, Keith, because I'm just thinking in my own practice, you see, in the future, I can see 50 patients following a myocardial infarction, and I have the data in front of me. And perhaps my reaction would be in a patient with a very high risk, diabetes, vascular disease, and so forth. I probably will be willing to use that approach as far as the patient is not too old, as far as the renal function is okay, as far as the patient is not too thin. You know, we are getting into a situation which from an academic point of view, this is a great trial and is a step forward. I don't think we have a question. But from a practical point of view, I want to see your reaction. You have been too involved with the trial, but let's assume that you are making an unbiased comment.
Well, you know, I think that, first of all, is it possible to identify this kind of population in our practice? And the key issue, and Jessica will want to comment on this, is excluding people with prior known stroke and prior intracerebral hemorrhage. And, you know, we've learned across the series of studies that the combination of antiplatelets and anticoagulants is really bad news in that population. A small number crept in. And there is excess hazard in those individuals. So I think Clyde's point is right. I think we've got to be very careful about this. But there's a paradox. And the paradox is, in atrial fibrillation, deliberately, this was 55% of the Rocket AF population had had a prior stroke. If you look at the apixaban trial, a substantial proportion of those had had a prior stroke. And in the absence of concomitant dual antiplatelets, that was effective. So it's the combination of dual antiplatelet and I think the anticoagulant that can give you the hazard.
Yeah, I think your comment about atrial fibrillation is quite pertinent, because there you don't use aspirin, you don't use clopidogrel,
exactly,
and you might have a previous stroke and still the drug works. Yeah. How would you answer the question in your practice in the future?
Well, I think it's great points in terms of clinical trials enroll certain types of patients. They may not always be generalizable, but I will say it's interesting looking at the data. There was a reduction across the board, so we might think, oh, I'll just give it to my STEMI patients, or maybe I'll apply it to certain types of cohorts. But it is interesting, the subgroups, there really was no heterogeneity. And so I think we have to be very cautious to interpret clinical trials in general when we think about our population. But it was quite interesting. Also on the bleeding side, there was no statistical interactions for other types of bleeding causes. And I think the one group that really stood out was a stroke and TIA. And I think we need to learn from prior experience, which we did. We learned from trials that we had been involved in to say that group is not going to benefit from additional antithrombotic therapy.
Jessica, do you have the same zeal for using this agent in, let's say, a much older population? I mean, we increasingly deal with individuals in their 70s and now in their 80s, you know, who are coming in with an ACS, they're appropriately going to the cath lab, getting a catheter-based procedure, coming back to the CCU, they're on a variety of antiplatelet, antithrombin drugs. And this is the group that I often inherit, you know, on the receiving end when they develop a significant bleeding complication, particularly if they've had a femoral approach. And so I have developed a very healthy respect for how these agents can interact differently in older people, particularly if they may also have compromised renal function. So what's your approach?
Yeah, it's a great question, and we intentionally designed the trial to not have an upper age cap because, as you point out, so many of our patients are in these age ranges where we want to have an understanding of what's going on. So we purposely did not cap the age. Now, with that being said, the number of patients over 75 did end up being somewhat, it's about 10% of the study. So as it turns out, we're going to have to be very careful when we treat these patients. And I think do our due diligence to try to include a broad variety of patients in our clinical trials moving forward so we have that information.
So, John, we have been talking about what you discussed at the very beginning, you know, how you decide who is going to be on a drug like this. But it is interesting, by looking at the data, I wonder if maybe the medication given earlier even would have a higher impact. You see, this case is within a period of a week, and really there is significant impact by many others antithrombotics in the first day or two of the acute coronary syndrome. So maybe it will become easier in the future to perhaps move towards that direction and with the highest risk patient. Are you, after this discussion, you still say, I don't know?
Well, I find that the lack of heterogeneity is is encouraging, that you remarked on, Jessica. But again, the application of a combination of such agents is manageable in a clinical context of specialized of specialists, if you will. So one of the questions that occurs to me really is how do you envisage the cascade of the use of this type of combination of antithrombotic, antiplatelet agent? Do you feel that this is going to be relatively easy? Do you envisage this cascade being relatively rapid through the different levels, if I could say that, of specialization, of knowledge of clinicians in the area of ACS or not?
So it's getting more and more complicated, isn't it? Trying to sort out all the antiplatelet agents, sort out different genetic factors, who's going to respond to drugs. I think as an agent, as we talked about, there is biology and there's reasons why this could work. I think physicians will get comfortable with these new agents. They're going to be available for atrial fibrillation. But to Keith's point earlier, the dosing is different. The dosing here is about a quarter of what is used in atrial fibrillation.
Which is 10 milligrams, isn't it?
No, 20.
20.
20 milligrams, 20 milligrams. Yeah, that's right.
So this is a quarter, and so I
It's
think...
twice a day, yeah. 10.
Right? And so we're going to get used to these medications, but we're going to have to get used to the different dosing issues. And it was only after 6 years of experience, and we started with a very large phase 2, over 3,400 patients, to try to find the right dose, but it is a different dose.
Keith, I have a question about the twice daily antithrombotics. I always had some problems with the rebound phenomena. If you miss a dose or two, what do you think?
Well, the interesting thing is that was studied in Atlas, and the events after discontinuation, and there was no excess. So at least that was very reassuring.
Good. Well, it seems to me that the study certainly has been a significant step forward. I think it's worth the discussion of the first paper tonight. But I'd like all of you to now compare another study, which is thrombin receptor antagonist vorapaxar in acute coronary syndromes, which I'm going to quote Keith Fox, what he says. He says, the study's name, the name of the study is TRACER. It says, TRACER has missed the sweet spot between efficacy and safety. And what I really like to do is to compare the efficacy of both trials and the safety and see whether the differences were so significant. So let me go into the study. You know, the thrombin receptor on the platelet has been in the minds of all of us as a possible new antithrombotic approach, and now we are beginning to see the results. Again, it has been a question of bleeding, and the reason is very simple. Here is an attack, open attack to the platelet. That is, you are attacking the receptor, probably the most important receptor of platelet activation. And you are not attacking the fibrin. Mm-hmm. Therefore, on one hand, you may have fibrin forming. On the other hand, you are only preventing the platelet very aggressively. So the question of efficacy, question mark, and bleeding, question mark, has been in the minds of all of us. So I think this is an interesting aspect on theoretical basis. Let's go into the actual study. The study was also published in the New England Journal of Medicine yesterday. The first author is Dr. Pierucci Tricosi, and this was presented by Kenneth McHeffy, and actually was discussed again by Keith. I cannot get rid of you today. But anyway, you will have to defend a number of things in a few minutes, though. Let's go into the study. As I mentioned, vorapaxar is a receptor blocker of antagonists of the thrombin receptor on the platelet. And this was, again, a double-blind randomized trial in which vorapaxar, given orally 40 milligrams as a first dose, a loading dose, and then 2.5 milligrams maintenance dose, was given in a randomized fashion over a total number of over 12,000 patients that were randomized into placebo and the drug. And actually was given very early, within the first 24 hours of an acute coronary syndrome. Now, the primary endpoint, in this case, I'd like to mention that the syndrome was non-ST elevation, so it was a particular group of patients. Now, the primary endpoint, interestingly, in this case was the composite of death from cardiovascular causes, like the other trial, myocardial infarction and stroke, like the other trial, but he's added recurrent ischemia with rehospitalization and urgent coronary revascularization. And then the secondary endpoint is exactly the primary endpoint that was on the previous trial that we discussed. Now, the follow-up of this trial was, actually the trial was terminated early after a safety review at a median follow-up of 502 days. The primary endpoint, to make a long story short, 18.5% events compared with the placebo 19.9, with a p-value of 0.07, an 8% reduction, not statistically significant. What is interesting is when you go into the composition of death from cardiovascular causes, myocardial infarction and stroke, the results were very significant, like it was in the previous trial. But apparently here, on a statistical basis, if you fail the primary endpoint, you cannot talk about superiority on the secondary endpoint. But it's interesting to see how the differences are not so significant. In fact, in this case, it was interestingly myocardial infarction rather than mortality, rather than death, was by itself very significantly reduced in this particular trial. And then we go into what made the trial to be stopped. The trial was stopped because of bleeding. And the bleeding rates were actually, intracranial bleeding was 1.1% versus 0.2%. In the other trial was 0.6%, I guess, versus 0.2%, and this made the trial to be stopped. I only want to present to you the following discussion, and that is, when you dichotomize both trials, I can imagine that I would have decided from the beginning that the primary endpoint was going to be what the secondary endpoint was. Stroke, myocardial infarction, death. And then the bleeding rates are not too different than on the other trial. So what I'm really asking here is we are maneuvering so minor things that makes a trial successful and the other falls apart. So this time I give you the possibility of making a comment. You discussed this trial.
Well, in my comments as discussant, what I said was that the soft endpoints only added noise. Secondly, if we look at the distribution of the events in the trial, half of the events in terms of the efficacy events were within the first 4 months. But actually, 80% of the intracranial hemorrhages were after 4 months. So here's a trial where it's stacked towards the earlier phase for the efficacy endpoints, but the hazard in bleeding and intracranial hemorrhage continues over the course of time. I'm not dismissing this trial at all. I think it's a very interesting mechanism. The binding of vorapaxar to the PAR1 receptor ends up having a very, very long half-life. So you have a potent inhibition with a very long half-life in the presence of dual antiplatelet therapy. So I think it raises the question of whether a smaller dose or even a once-weekly dose could work in this setting. So I don't dismiss this. I think it's a very interesting mechanism, but I think the truth is it did miss the primary endpoint, and there were 2 TIMI major bleeds per 100. I beg your pardon. 2 gusto bleeds per 100,
yeah.
5 TIMI major and clinically significant bleeds, and almost 1 excess intracranial bleed per 100, against an efficacy trend of about 8%.
Keith,
On the primary endpoint.
On the primary
yeah.
endpoint.
If hypothetically the secondary endpoint were in fact the primary endpoint in this trial, would you
Well,
feel
that's
differently?
the question.
I mean, because Gene Brownell always says there's no such thing as a free lunch.
Yep.
And we all know that what he
Yep.
means by that. But would that change your view here?
Well, I think this is close to where there's something important. But if it was your patient or mine, and we were balancing that relatively modest impact on efficacy against that number of major bleeds, that's a difficult balance.
Yeah, I would agree with you, Keith, because I think that hazard ratio for intracranial hemorrhage was 3.39.
Yeah. Right.
So I would really be reluctant to look at that as a potential efficacious compound unless the benefit was really substantial.
Yeah.
But modest benefit and a tripling or worse of intracranial hemorrhage with dire consequences when
But
that
was
occurs.
fourfold on the other one, on the other trial. The hemorrhage, measure hemorrhage. So we are not too far, I can tell you, when you look at the data in terms of hemorrhage. The point is the efficacy is different because we have a primary endpoint, it just didn't work.
I think also the fact that the mortality benefit with having a reduction in CV mortality, I think makes people pay attention. I do think there are actually some encouraging signals in the TRACER study. As you mentioned, the secondary endpoint, there's a reduction in MI. So there's a signal there. And to Keith's point, maybe this is an interesting dosing issue once again. And we're learning a lot about dosing and potentially the importance of phase 2 trials. In this study, there was also a bolus dose given up front.
And maybe not the patients, there were patients that were not excluded, like they were excluded on the other trial.
I don't think that's fair. But I think that there was heterogeneity among the subgroups, and that heterogeneity is on those who got dual antiplatelet therapy versus not. So there was a separation of excess hazard with dual antiplatelet. So we're coming back again to this interaction between dual antiplatelet and aspirin alone.
And what is your reaction?
Well, this is a complicated study for me to interpret, but as I think about this, trial design today is really high stakes because we're talking about a major investment, a large number of patients, and here, as you've mentioned, the primary composite outcome was a large number of variables that increases the risk that you may not see a significant outcome. I do agree that there is a signal here that the drug has potential benefit, but as a clinician very concerned about the bleeding complications that are happening later and wondering if that risk will continue to increase over time. And then I think there's a significant difference between a major bleed that you can treat and an intracranial hemorrhage that even if someone survives, leaves the patient generally significantly disabled. So I would have major concerns about this therapy as employed in the trial. But it gets back again to the complexities of using additional drugs with dual platelet therapy that is considered standard in the management of patients with coronary disease today.
John?
This is a marvelously interesting discussion because I think it crystallizes a question with which we're constantly confronted. How does the benefit-risk ratio of a given pharmacotherapeutic approach potentially change over time? And if you do excuse me mentioning this, exactly the same question occurred today in the AIM high trial with respect to niacin that Bill presented. So it's the complexity. For me at least, it is really a challenge.
Yep. But I think that for us to stand back as clinicians the tough decision is going to be aspirin plus ticagrelor, in my view.
Yes, I agree.
Versus this kind of strategy. And I think all of those have got to be on the table. And standing back, these are the kind of options that are out there.
I agree.
But I think we shouldn't hesitate to say no, because we're looking at a data set that investigated a different way of approaching the issue of anticoagulation that has a real risk profile and has a very modest, if any, benefit profile. Sometimes we just have to say this didn't work and invest our energy in a different place.
Yeah, you know, I guess we know that for LDL, lower is better, and maybe the same principle applies to anticoagulant therapy in terms of dosing. Lower may be better. And I think we're seeing some themes here that are emerging. And I think all of us who take care of these patients worry a lot about bleeding, and we know that bleeding drives events. And so I think it's increasingly important to not lose sight of those potential issues.
Well, I'd like to to summarize this discussion thus far as a discussion by a number of academicians who are really looking at the detail of a study in which patients were highly selected. And we are looking at minutiae. And the question is, as we discuss, all of us, I think, are in agreement, how we manage the patient in front of us. This is actually going to lead to the third topic, which to me is interesting in the context of what we have discussed thus far. And this has to do with adherence to medications. I just gave a talk this afternoon, actually, about compliance of lifestyle. Compliance means fluctuations versus adherence in terms of medications. And all of these evolved from our own freedom trial, in which we don't know the results, but these are diabetic patients with multivessel disease, in which we are really hammering the patients to take the drugs, the medications to control risk factors. And at the very end, we reviewed if they are taking the medications or not, and only 20% of the patients, only 20% are taking all the medications that they are supposed. And then we went into other trials, and we find the same thing. So that was the interest in looking at the subject, because we can prevent events by 2% to 1%, when in fact we are not giving the drugs they are supposed to be in about 80% of people. So with this background, I think it's important that we discuss this particular study, which was presented in this meeting, full coverage for preventive medications after myocardial infarction. This actually was led by an insurance company, by Aetna. And the question was, if we have full coverage, we give you the medication for free, is your adherence going to be better? And if your adherence is better, it's going to be a lower cost for the insurance company in a long term to take care of you. And the answer is, without going into the details, this is correct. In other words, very basically, this is a study in which patients who were discharged after a myocardial infarction were randomized into a complete coverage. These were 2,800 patients versus partial coverage, which were 3,000 patients. And the drugs that they were involved there were statins, beta blockers, and angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. And here comes the primary and secondary outcomes. I don't think it becomes clear, but the primary outcome was the first major vascular event or revascularization, and the secondary outcome was one of the two, and in addition, health expenditures, adherence, total measured vascular events. But I'd like to provide with the data first about adherence. The adherence to the medications following myocardial infarction was actually about 40%. So 60% of the people were not taking the medications they are supposed to. This is a trial right now, which is not different from what I was presenting this afternoon looking at other studies. So that to me is the most important thing. Then when they go into the outcomes, what they see is if you are fully covered, your outcomes decrease. And interestingly, for insurance company, that's better. It's cheaper. So this is basically the concept. And what I would really like to discuss here is that we are really moving with p-values, moving mortality from 1% to 2.5% and so forth. And here is a huge problem, and that is patients are not taking the medications. And at least the FOREST study, the pure study we was reviewed here, actually recently in the European Congress, when we have together with the review the pure, which is worldwide, in which was amazing, is about 50% of the people are not taking the medications in high-income countries. When you go to low-income countries, only 10% of the people are taking the medications. I really bring this to discussion because this is one of the gaps I mentioned before, and that is the gap between the academic world, the way we deal with trials and minutiae and so forth, which always we make medicine to advance, versus what is really happening outside, which is a problem. Maybe, Bill, you can comment on it.
Yeah, it's a very, very valuable point, and I think this is a very important study. It reminds me very much of the criticism we faced in the aftermath of Courage. A lot of people didn't like the result. And one of the criticisms was that the optimal medical therapy that we employed was too good. It could not be replicated in the private sector, or it could not be replicated in the real world. Now, in Courage, Big Pharma was a major supporter along with the U.S. government, and the medications were provided free to the patients. So we had remarkably high adherence rates to aspirin, to other antiplatelet therapy, to statins, beta blockers, and inhibitors of the renin-angiotensin system. And I firmly believe that because of these disease-modifying therapies, it did level the playing field. I think it contributed to why we saw no difference in the two strategies. And it's not just that one trial. I mean, we have many other trials that have convincingly shown the same thing. So why is it that in spite of all of the evidence that has been marshaled from multiple studies, why is it that we still fail in over half the patients to not administer medical therapy?
You know, Bill, I reviewed this, and let me give you figures. You know the time that a doctor spends with the patient discussing a new medication? The average time, 47 seconds. Yeah. There are already 2 studies showing that. And what happened is the physician, if the physicians are asked, is your patient following adherence to medications, 80% said yes. And if you ask the patient, are you following the medications, and the patient doesn't tell the doctor, 70% of the patients, they don't talk to the doctor. Whether you say, what are you taking? But really, not necessarily they are taking the medication. So there's an issue of communication that is tremendous here. And I think this is a problem.
But also, maybe this is a lesson that we need to think about a different paradigm. That is to say, this is not necessarily information that a physician has to give to the patient.
I agree with you.
You know, so why not expand this to include nurse practitioners and other health providers? They can do. I mean, that's what we did in Courage and in many other studies. I mean, it can be achieved short of a physician.
I couldn't agree with you more. We've used that model in our atrial fibrillation clinic, where we use our nurses to educate patients about the medications that they're on, why they're on them, follow-ups in terms of, are they having side effects, are they having recurrence of arrhythmia, and then a rapid turnaround time in terms of response to changing doses or changing drugs. I think we really need to learn more about why patients aren't taking their drugs. Is it because of side effects? Is it because of lack of education? Is it because they're taking too many at the same time? Because I don't think it's just cost.
I will tell you, we have a study with a polypill in which is supported by the European Commission. And we have 2 studies. And the first study is why adherence is so poor. And I can only tell you, we don't have the results, but we have reviewed the whole literature. And I have to say to you that one of the key issues are not demographics, is the patient doesn't know enough, doesn't know the side effects, feels fearful, the doctor has not told enough about the patient, and so forth. And I think the answer certainly appears to be to have a system, because the doctor doesn't have time to do that. John, what is your feeling?
Well, there have been some recent events in France that perhaps I could mention briefly. One or two agents which have been available in the pharmacopoeia in France for the last 20 or so years, in the absence of a substantial database, evidence base, have recently come, let's say, into disrepute on the basis of a very high frequency of unsuspected adverse effects. And what has happened is that patients, of course, have become informed. There is an explosion of judicial proceedings around these agents, affecting several thousand individuals. And what has happened is that, and we see this in our outpatient clinics for prevention of CVD, and particularly these are multiple risk factor clinics, patients increasingly are doubting the validity, the efficacy of drugs that have really been shown to bring benefit in terms of reduction of events. And I think we're at a watershed in this whole area, and the type of approach that Anna's mentioned, which we've not implemented or is not implemented in France at this time, will have to come because of the tremendous pressure on my colleagues in our outpatient clinics to respond to patients' questions, and simply the pressure is such that they're unable to.
There's no time.
That's right.
This is the issue. Keith, what is your perspective from the European side?
Well, actually, the figures...
you are European too, I'm sorry. but excuse me, but he's British, and you are French, and the European
I'm Zimbabwean.
Union is in big shape. Go ahead.
But, you know, actually, it varies by country. And there are countrywide factors that influence this. At the European Society of Cardiology, we presented a paper that was published as a fast track, which was not on a trial. It was on the MINAP program, which is every patient admitted to every acute hospital in England and Wales with a suspected cardiac condition. We then linked this with the general practitioner registry of prescriptions. And I can tell you that the validated figures for statins at a year were 90%. For dual antiplatelet therapy, it's down to 60%. But it is possible to get better figures in different systems.
Jessica?
So I think there are two key points. One has been raised about education. I think patients truly don't understand why they're on these medicines. I think they have the capacity to, but they don't make someone feel better. Patients take medications when they have a cold and they need to take something to make them feel better. And I think we have to explain, this is not going to make you feel better. You're not going to know your blood pressure is going down. The second thing is really understanding the motivations. And it sounds like you really think it is time and education. And to give Aetna another idea, maybe they should start compensating people. Maybe they would do even better if they gave people some money and we could reduce events even further. I say that half facetiously, but I think we have to figure out what we can do to help motivate people to take medications.
One of the things being discovered with all this adherence is that actually, in terms of medications, the patient becomes its own doctor because doesn't have enough information, doesn't know about the side effects, doesn't know if I don't take the drug what will happen to me. So the patient actively makes decisions. And this is where the whole problem begins. I think it's a new field that we really have to pay attention to. Clyde, what do you have to say?
Well, this session was the one that I moderated, and so I had a chance to look at these data very carefully. I think this is really a very important study because even with all the caveats, post-MI FREEE demonstrated that the provision of the medicines led to a significant reduction in important events with $500 fewer out of pocket for the patient per annum and no extra charge to the insurance company. We've been looking for the big idea in the new healthcare environment, And this could potentially be the big idea. Now, to the point about having mid-levels or others do the education, we shouldn't rush to that too quickly. We really need to know how that takes place. There were data presented in the same session where introducing a pharmacist to coach the patients through the best application of their heart failure medicines had no impact on meaningful outcomes. So there is a way to do that that will require specific kinds of health services research. But here's the other part about this. So you take a big idea of making the drugs available free of charge, but you use a traditional study endpoint, morbidity, mortality. We need to begin to think about what is the endpoint that really matters to the patient. Take a patient-centered view. I submit to you that if you tell a patient you will do just as well as you would have done, except it will cost you $500 less per year, that's an important outcome to a lot of patients. Now, you can't go back and reconfigure the study and make that the primary, but we need to move to an era where we're not only looking at health services research, but we really are looking at the things that matter to patients. Because as you said, Val, we can be very academic and look at p-values and look at curves separating and being parallel. Patients that's irrelevant to them. But saving money and feeling better is actually pretty important.
Yeah, well, it's interesting. As I mentioned at the beginning, these are the two gaps I can see that we have in our specialty, maybe in medicine. And one is the technology is overshadowing the contact with the patient. That's number one. And the second is the reality of all these trials and what we face and where the patients are going to listen or not, because we don't tell the patients. We spend our time talking about the trials. But the question is, are we talking to the patients? I'm just being, but it's a reality that we really have to face.
There's another potential factor here, at least in the United States. So much of healthcare is subspecialty directed. And we continue to see patients who bounce among various subspecialists. And I guess I wonder how much of a factor is the missed handoff back to the internist or the PCP, and to what degree do patients get confused because they often get conflicting information, and perhaps there's not consistency with how we need to reinforce the importance of medication. We know, for example, that often clopidogrel is prescribed for a month. And what that tells the patient is, I only need to take it for a month, as an example. So I just question whether, our system of healthcare in this country, is also part of the challenge that we face here.
Could I just perhaps make a rapid comment here? A very interesting event in France that has not been discussed widely and is not realised. About 5 years ago, the Paris hospital system decided to create what we call poles for care, or care poles. And in our hospital, we had 77 distinct clinical services. We now have 11. And each of those 11 contains a grouping then of clinical services which are interactive around a specific group of pathologies. And that we are receiving very positive comments from patients because they're not subject to this type of circumstance.
Just to finish, I'd like to say that the person who presented this paper and is the first author is Dr. Chowdhury from the Brigham and Women's Hospital in Boston. I'd like to finish by asking, perhaps starting with you, Clyde, is that what do you take from this discussion today, and what would be the message that you would give? Maybe you want to think for about a minute.
I think I just had the minute. I think it's exciting that we're exploring new directions and we have new ideas. But it tells me that where we already are is a pretty good place. And as we introduce new concepts, we have to introduce them very carefully, very thoughtfully, and understand there's very little need to rush into anything at this point, but to really be very measured about the new discoveries. The second theme that comes about is that we have to begin to think about new kinds of research. The randomized control trial has really carried the water for so long. Maybe it's time for a different approach so we can answer some of these more pragmatic questions. And the third overarching statement is that I think even though we love our profession and we believe that what we do is noble and appropriate, have we missed the patient as we have embraced the profession? And should we not find a way to become more patient-focused? That applies to adherence, that applies to everything we've talked about tonight.
Thank you. Jessica?
I think to follow up on those themes, there are two big ideas that come through to me. One is looking around, getting the right dose for a patient. So we've talked a lot about dosing during this meeting. And then the second theme is getting the patients to actually take these doses, and whether that means becoming more patient-centric and really taking the time to explain all these therapies that we love to sit around and talk about. I think we have a lot of work to do, but it is a very exciting meeting for that reason.
Thank you. Keith?
In all of our countries, there's the challenge of actually implementing what we know works. And I think that is absolutely crucial. I think the second message is we've got to be careful about the balance between efficacy and safety.
Thank you.
And to build on that, as has been discussed, it's all about individualizing patient care, making the appropriate decisions for the given patient.
Personalized medicine, but at the contact
Yes.
way, not at the molecular pharmacological
Not at
way.
the molecular or pharmacological level.
John?
Fascinating discussions, because we found ourselves at the extremes of the spectrum. On the one hand, we all agree that clinical trials are absolutely essential to evaluate new agents and to fit them into appropriate points in our armamentarium. But at the same time, we realise that those clinical trials, while driving our guidelines and absolutely necessary for our guidelines, are not exactly situated in the real-life patient care context. And somehow it seems to me that we need to really change our conception of trials in such a way that they are more directly in contact with patient needs. That seems to be, to me, to be a major message from our discussion this evening.
Thank you, John. Bill?
You know, so much of drug discovery and development and application focuses on the acute coronary syndrome patient, and clearly we've made profound progress. I think the thing that I think is the biggest challenge that we face is from a population health standpoint. If you look at the things that will actually most impact favorably how patients can live longer and can reduce, incident cardiovascular events, is to apply evidence-based medicine, apply the drugs and the agents that have been shown individually and collectively to be of benefit. I mean, we all worship at the altar of evidence-based medicine, but I'm dismayed at the fact that we do such a poor job of applying the principles of evidence-based medicine to our patients.
Maybe my comment in this regard is agree. I think we are all talking in the same way. I would say that 3/4 of the world cannot afford the medicines we are talking about, and unless we really pay attention to this aspect, I think we are missing the boat too. So I think this discussion today, as I said at the beginning, was going to be interesting and quite challenging, intellectually challenging, and I hope you found so. I really appreciate all of you being here today. Has been wonderful, educational, and I hope I see you soon. Thanks very much.
Thank you. Thank you.